everyone, and welcome to another one of our Sam's Diamonds videos. And I have the utmost pleasure to have the absolute legend of a surgeon, my surgeon, Professor Audisio. We have remained friends all these years, which is just a testament to how he treats his patients. He's now living in Sweden, is that correct?
Correct.
Living in Sweden, and he is a lecturer in surgery out there. So his full title is a Professor of Cancer Surgery at the University in Gothenburg, Sweden. Gothenburg, is that right?
Correct, correct,
So
correct.
he's enjoying himself out there. So can you just tell us a little bit more about what you're up to these days, Prof?
A little bit of a switch of career, where I moved from the UK to Sweden because I had better opportunities to expand research and education and training. I have several PhD students who are conducting numerous research in different fields, and I find it very fascinating. Of course, it's important to treat patients, but it's also very important to educate young generations of surgeons to deal with their breast cancer patients in the most appropriate way. So this is what really means a lot to me, and that's why I've moved to Sweden.
That's brilliant. So you're bringing more and more people up, aren't you, to help with the situation?
That's very rewarding. I think it's the best thing to leave a legacy behind you. Otherwise, everything faints and falls apart.
I think you're leaving a legacy anyway, but they're going to be learning from the best, so they'll be made up. They'll be made up. So
right. Yeah, as you might know, I have many interests in surgery, cancer surgery, and breast cancer surgery is such a fascinating topic where we are always continuously, progressively improving, understanding, learning, and so. But like I said, you might be aware that one of my hottest area of interest and expertise is breast cancer in older women.
Yes.
And unfortunately, this is not really a very sexy topic because of social, financial, ethical, economical misjudgments, and older people are undervalued in our society. But the fact is that mankind used to live 35, 40 years until the Industrial Revolution. And from there on, the last century and the beginning of this century, 75, 80, 83 years of life expectancy. And this is because the above 60-year-old segment has relentlessly and progressively increased of 1% per year, so that the geriatric, the older population, has tripled over the last century. And now we have the above 65-year-old segment that has doubled, and the above 85 that has multiplied by 4. So this is dramatic now, and in the future is going to be even more, given that 1 in 3 babies born today in the UK will reach 100, will be centenarian, which is dreadful for the Queen, who has to sign all the telegrams, but it's very good for the population. Not only we live longer, but we have a longer healthy life expectancy. That is, without significant geriatric symptoms without falls, without lack of cognition, and therefore we expect to live longer and in good shape. And this is why I'm quite passionate to make sure that patients are for best treatment, all the patients are for best treatment, and physicians are aware of this, together with politicians, together with with nurses, all the community who is involved into giving treatment to patients, and particularly older patients.
I agree.
So we are living longer and longer and longer. Not only we're living longer, but second point that I'm making is that cancer is a disease of older people. Cancer very, very seldom affects younger women, whilst 1 in 10 above age 70, 75 will have breast cancer. Therefore, when I first discussed this data in Boston, I was attacked on Twitter or on Facebook, I can't recall, because they said, oh, this guy is mad, and I don't want to undermine the dramatic, painful, awful scenario of a young lady who develops the disease with the side issues of family, sexuality, job, kids, and all together. But fortunately, this is quite unusual, while it's very, very, very usual, very prevalent for all the people to become affected.
So would you say that you think that the older people seem to be getting pushed to the side a little bit because they're concentrating on younger women now these days, because it is going younger and younger? Are you just worried that they're going to start pushing aside the older generation?
No, I'm not worried. I'm confident we have horrible data showing that survival for breast cancer is better and better and better. But when you reach age 70, 75 in the UK, survival drops. And this is patients dying of cancer. It's true that they are old, they are 70, 75, 80, 85, but they don't die for other conditions. They die because they are not treated for breast cancer. And this is not just a UK issue, which is true for Manchester, for Merseyside, where we have data for the All England registries, but it's true across Europe. There is a Eurocan project that really demonstrates how the drop is awful, and it's the same in the States, and it's the same around the world. Now,
Ralph, do you think that that's because it's like a double-edged sword? Like you've got, I know that I'm dealing with like relatives and stuff who are older age generation, and they're so, how can I put it? They're very much, I'll be fine, I can deal with it, blah, blah. So do you think they don't come and get it diagnosed early enough because they're so, I'll just get on with it, I'm fine type of person? Or do you think it's just that they're not getting the treatment, access to the treatment?
This is one issue which is very, very important, because I struggle to see how we have patients coming from residential homes, nursing homes, that have been there for 3-4 years, and they come with a huge fungating mass. Who baths these ladies? Who showers them? I mean, somebody needs to look after these patients, right? But yes, you're right in that the awareness is very low. My mom, for example, she believes that she is immune to breast cancer. Because the Angelina Jolie and Kylie Minogue effect attract the attention on younger patients, often on the front cover of the tabloids, and she believes that breast cancer is not affecting the older segment, which is not right. but also she believes that when you're older, you don't deserve any treatment. And you are actually untreatable because of you're too old to be treated. But
Yeah,
this
I've
is
heard that a lot, you know, I do hear that a
yeah,
lot.
this is not my mom. This is really ordinary patient, ordinary population. Um, and I think that there is an ethical issue here that our community kind of dismisses all the patients. I mean, this is guys who, I'm not talking the, you know, disabled, um, mm, demented patients with questionable quality of life. I'm talking fit people who go skiing, sailing, walking, cycling, and they have a very ordinary life. And I want them to be up and running as long as they can. I don't want them to die for a condition that can be resolved in a very, very simple way.
Yeah, but their age,
No,
they're thinking their age is going to get in the way, don't they?
yeah, they think that the edges think that it's untreatable. And this is an issue because communication with patient is crucially important. When you communicate with someone, you need to make sure that you deliver your message whilst you are also open to understand the opponent's message. And the same is when you're talking with patients. Patients should try to understand, and therefore it's your duty to make sure that what you're delivering is delivered in a way that the patient can understand. Because if you use big fancy words, they get just scared and they say, oh, no, 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 no,
Yeah,
leave
yeah,
me
yeah.
alone. And if you appreciate that 1 in 2, all the patients above 70 is malnourished, 1 in 2 is lacking cognition, 1 in 2 is lacking mobility, is not comfortable in moving, and 1 in 2 is lacking continence. So you have someone in front of you that you need to understand there is a different patient, a different person as a whole. And that's why you need to deal with this human being in a very special way. And therefore the communication is particular. When I go to the multidisciplinary meeting and my colleagues used to say, oh, this patient is not for surgery because she's very old. Why? Oh, she doesn't want like needles and I don't want surgery either. Nobody really likes surgery. But if you tell this patient that they can sail through the operation, that it's pain-free, that is going to be useful and effective, and most likely is going to eradicate and cure the patient, then they say, oh, I didn't know that. Let's go for it.
Yeah, yeah.
I give you 2 funny examples, if you don't mind, which really shocked me.
What?
Yeah, I want to give you 2 examples that's really helped me a lot in understanding how things are experienced by patients. Once I had a lady, an elderly lady, who came to me through casualty because she fainted. And she fainted because she was anemic. And she was anemic because she had a large breast cancer, which was bleeding and ulcerating. And so I said, let's get you sorted. And she said, no, 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 I don't want it done. And I couldn't make it. I couldn't convince her to get the job done.
Why
Are
do you
you
think that
sure?
was?
Yeah. Sorry?
Why do you think she didn't want it done?
She didn't want it done because, no, 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 I don't want it done. I don't want it done. And I couldn't really squeeze out anything more. I gave her a transfusion and hemoglobin was back to normal and she went home. 2 months later, she came back through casualty, fainted again. And I said, listen, this is really not good because you see this one is bleeding, it's causing you lots of problem, and why do you not really want it done? She said, because I've been married for 65 years, I've never left my husband for one night, and I'm not going to do it now. And
Oh,
this is when you can talk to this patient and say, listen, this is a day job. You're coming in the morning, we deal with it as a day case. You wake up and in the evening you're home. And say, oh, but then you tell me and then it's done. And the week after I operated on her. So you see, sometimes it's us not being able to understand what the patient's problems are.
yeah.
And this is quite peculiar in the UK. And that's the second example, because with Age UK, we had to set up a task force of dog sitters, because one of the main reasons why all the ladies don't want the operation done is because nobody can walk the dog whilst they are in hospital.
Oh.
So this is, you understand, is not the top priority that comes to your head as a brilliant scientist or a good surgeon. This is really something that you wouldn't be inclined to understand unless you really talk to people and you empathize with people.
Give them the
So
time.
this is
The thing is,
a good.
with both of those situations, whereas they're trying not to leave the husband for one night and not be able to walk the dog, if they don't get it looked at and treated, they won't be around at all anyway. But they don't think that way, do they? Do you know what I mean? You're going to be leaving them on their own without you if you don't get it treated. It's crazy. It's crazy.
I know, but that's the way as it um, unrolls. So what I want to say is important to talk to people, but also to understand that we have to understand what the problems are, and we have to give opportunities. So on one side, the bad news is that there is lots of breast cancer. It's on the rise, and it's predominantly affecting all the ladies, that they should be aware that is most likely to happen to them. But at the same time, you want to give the message that it is very treatable. There is no patient who is not surgically treatable. And most of the time, beside treatment, it comes with cure. It's most likely to be cured. So I'm quite passionate about engaging with all the patients with breast cancer for the purpose of delivering this strong but kind of positive message. Not only surgery is a very good option, but radiation has no contraindication. Hormonal treatment is very effective. Chemo, if needed, can also be given. For example, in Sweden, we have looked at the national registry all over Sweden for the last 20 years, and looking for HER2 negative, triple negative, all the women, how were they treated? Because triple negative patients have no benefit of any hormonal treatment and have no benefit of Herceptin. So these are really patients that either you give them chemo or you don't give them chemo. And we know that giving chemo after surgery, when the cancer is out, is very beneficial. But in the UK, most of the time, oh, she's 75, 80, 85, we don't give chemo. Because we really were not convinced that chemo was beneficial for this lady. And looking at all these Swedish patients over the last years, we have had the opportunity to confirm that the survival gain, overall survival, and cancer-specific survival was much better for those who received the chemo.
Right.
And because, and I'm talking 75 and above, to double check these with colleagues and friends in the US, we look at the SARE database, the national database in the States, and we could double replicate the experiment, and we reached the same findings.
Oh, wow.
So this is very, very strong new practice-changing figures.
And how do people over the age of 75 cope with chemo? Are they okay with that? Because it does take a lot of wear and tear on the body.
Of course, I'm talking fit patients, because you need to understand that you have very, very frail individuals among the elderly group. And this is 15, 18, 20%. 1 in 5 is very frail. And you don't want to aggravate the quality of life of a very frail patient whose life expectancy is short, who is not going to live longer than 2 years. Then on the other extreme, you have fit patients, and you know how many elderly and super fit women are around. You can see them shopping and enjoying themselves when you're traveling and so on. And in between, there is a foggy gray area of vulnerable patients who are not super fit, but who are likely to receive poor treatment, worse treatment, if not no treatment, simply because they are not elderly but super fit. These are ladies that you correct malnourishment, problem with the heart, so you ask for the cardiologist to check them out and to adjust medications, whatever needs doing. And these are patients that are going to do very well, provided you spend some extra time in improving their quality of life. And that's a strong message that I wanted to deliver.
Yeah, they've got to be healthy, haven't they? Because you're only helping yourself. And we try and do that with Sam's Diamonds, with all the ladies who've been through treatment. It's about maintaining the health or getting the health back, because if it does return, you want your body to be stronger and healthier, ready to deal with it again the next time, you know.
Yeah, but Sam, you know that we are because we are in a consumistic society and we like buying and selling and we make money out of it. We live on medication, chemotherapy and whatever. Chemotherapy might increase survival overall, maybe 5, 6, 8%. 10 if you consider Herceptin. Now, healthy lifestyle and healthy food, physical exercising, and good style of life, everyday exercising is likely to expand survival gain of 20%.
Wow.
We're talking big. much higher. What I want to say is that, of course, we want to sponsor medication and whatever, but were we good enough to take good care of ourselves, eat well and move our legs and stretch our arms and do a little bit of work? We don't need to walk to win the marathon every day. The 10,000 steps a day are more than enough. There is actually no gain beyond that threshold. So this is a very strong message. This is something that you perhaps want to promote. This is good because you can help people to prevent cancer, and you can, and it's also helpful, extremely helpful, past the cancer treatment in terms of not having a recurrent or delaying a recurrence.
We're working on that.
Very important.
We're working on that.
I know you are, but get your friends on board as well. That's very important.
Will do. It is massive, isn't it? It is massive. Now, I've got some questions for you off the girls, Prof. Are you all right answering a couple of them?
Yeah, I'm fine. Thank you.
Okay, let's see. So we've got, let's see. Right, can you ask, this is from Carol Ann, can you ask what, if any, research and treatment has been found in treating HER2 enriched breast cancer? Any new research around that?
Well, HER2 is actually a very small subsetting of breast cancer with a very serious prognosis due to the lack of treatment that we experience. But now that we have Herceptin, HER2 is actually one of the most advanced and more treatable, if not curable, breast cancer. So I think that this is really a success story of targeted treatment. And this is where modern oncology is revolving, is moving forward to identify some specific markers, hooks on the cancer cells that are individual for this cancer, that can avoid overtreating all other cells, damaging all other cells, including the body of the patient, and targeting only specific cancer cells, which is actually what is happening for HER2 positive patients.
I think it's triple negative, isn't it? Triple negative's the one that's hard to treat, isn't it? Do you know of anything coming around with that?
Triple negative is a little bit of a sad story, because for the time being we are lacking any targeted bullet for this group of patients. But I'm sure that something is coming soon.
Yeah, they're working hard on it all the time. There's something new every week, isn't there, that's coming out or getting tested. Next question comes from Catherine. Catherine says, one second. Catherine says, can you ask him whether he thinks more will be done soon to help the early detection of recurrent breast cancer, localized, regional, and metastatic?
Yeah. This is a huge, fascinating new story, which is being developed over the last 5, 6, 10 years, perhaps. In fact, I knew the lady who actually was the first who originated all these, and I'm thinking of liquid biopsy. So here comes this lady who is pregnant, and because there is some familiar disease, she had a blood sample taken, and with some advanced technological tricks, they were looking forward to detecting the genes for the disease, and actually they said, no, this doesn't match. And it actually matched with breast cancer. Oh. So they were the first to identify the possibility of spotting affected cells within the blood.
Right.
Which is now feasible, and it's actually implemented for lung cancer, for example, for many conditions, that with a simple biopsy, with a simple blood sample, you can be informed whether the cancer patient who is receiving chemo in view of achieving remission, regression, shrinking the cancer, is responding or not, because there are less of them. Whether the patient who is on follow-up does not need any further investigation because there is no cancer cells floating around, or whether a patient with metastatic disease is responding to the treatment or not, because you've noticed that there is a drop in these cancer cells. These are really little proteins that are part of the genome of the cancer that help us detecting the presence of cancers in the body.
I think it would be really good. The girls and I were talking on our Facebook page a couple of weeks back, and we were saying that when we are sent, because we've had cancer in the past, when we are sent for our mammograms now, it would be really good to have a blood test as well. And I said I wasn't sure whether they could pick up a cancer in the blood. They just pick up an elevation of an infection of some sort. But
No,
that would work, wouldn't it?
Yeah, they can pick it up, but for the time being, it's very expensive and it's not on the market. But
it's always down to money, isn't it?
Yeah, it is. But as you noticed, your first laptop was very expensive. This one is 10 times better and costs a fraction of what it used to cost. So the technology is really helping us, and hopefully we can get better, highly performing tools at a very cheaper price. So I'm confident that liquid biopsy will be the future.
Do you think that will actually be rolled out, that when you have your mammogram, you have a blood test as well? I mean, is there anything from a blood test that they could find now? You know,
Yes,
like 2 years down the line afterwards.
This is happening now. This is happening now. So liquid biopsy is not science fiction. Liquid biopsy is in clinical practice now.
Right.
Yeah.
Oh, that's really good.
Yeah.
So hopefully we'll all be able to get one when we go for our mammograms.
Well, let's say that when there is some concern, when there is an inconsistency between a new symptom or a foggy finding on imaging, on a liver scan or whatever, I think that liquid biopsy should be asked and should be performed in clinical practice right now. I would not recommend it killing the NHS for one single patient, you know.
Yeah. Can I ask a question? This is just from me personally.
Yeah.
So I have no breast on this side, and I have a breast on this side. I get mammograms on this side, but nothing on that side. Do you know why that is? Because this is the side I'm worried about, getting the cancer back, but I'm mammogrammed on this side and that's it. Why do they do that?
Well, the breast cancer, which can affect women, and the contralateral breast is 20 times is exposed to 20 times higher risk of developing breast cancer if the contralateral breast cancer has been affected. So you have had a risk of developing contralateral breast cancer. I'm not saying that the risk is now nil, because you are exposed to the risk of the ordinary population that long time has gone, and the risk of the cancer coming back is close to zero. There is, although, the possibility that breast cancer, a new breast cancer, might originate from the right side, whilst the left was operated. And because it's operated, because it's removed, it's very unlikely that anything comes back when there is no glandular tissue, breast gland, to develop breast cancer.
Right, okay. So, but if they had a lump or something developing, they'd do something with that then?
Yeah.
Right, with you. Okay. Okie dokie. Let me just get the last question. And this is from Sam. She said, it'd be really interesting to hear what your top tips would be for people at the moment in the clinically extreme vulnerable group being asked to self-shield for 12 weeks. So any advice you would give to them? Yeah, and for any cancer patients who are recovering after cancer at these difficult times.
Well, I've been trying, I've been out of the UK for a while, so I'm not entirely tuned in with what's going on despite the fact that my daughter is based in Manchester, so I kind of talk to her frequently. And what I want to say is that different countries, different performance, different attitude. Leaving the dreadful scenario of from the Italian side, where you have residential homes with 400 elderly people infecting themselves, or whether you have GPs who go around visiting home confined patients and delivering the bug. This basically resulted with these 30,000 deaths that we have had. And regrettably, we lost the gold medal to the States, and now I'm afraid we lost the silver medal to the UK, because UK figures have exceeded Italian.
I mean, we've been told, Prof, we've been told not to, if you've got if you're vulnerable to, like you've had cancer or some kind of susceptible, if you're in the vulnerable group, you're not supposed to go outside for 12 weeks. You've got to self-isolate. But recently, like today or last night, they announced that they're going to start slowly allowing people to go back out. So things like they'll be able, instead of doing that half-hour exercise a day, they're going to have unlimited exercise time. And then they're gradually going to start taking us back to normal. Now, we've got the highest rates at the moment, but they're actually starting to let people out again. So I have a feeling it might hit back again. But have you got any tips for those who have got to stay in, just to help them to stay sane? What would you advise them to do?
Well, to stay sane, engage whatever activities you fancy doing. Try to avoid cooking too much and putting weight on, and some a little bit of physical exercising, Zumba or whatever it takes. There is lots on the computer. It's very funny. You can learn dancing, Afro-Caribbean dances. There are lots of tutorials on YouTube. That's your opportunity, once in a life opportunity. With regard to going out, because sometimes you have to go out shopping or whatever, make sure that you keep the distance and you wash your hands again and again and again, because most of the contamination, the mask, yes, but the mask is actually not really, unless it's a professional mask, it's not really conclusively proven to be protective. It's more protective for others in case you are affected, but for you not to be affected by others is actually useless, particularly surgical masks. What is really important is to keep washing your hands when you go to the supermarket, that you push your trolley or you hang at the bus, on the train. Remember to I think the mask is very useful as a psychological deterrent, because you see people in a mask, you wear the mask, you understand, you remember that you are in a vulnerable situation, and therefore try to keep the distance, try to avoid the contact. That's the only, but don't get insane by all means. Keep exercising, learn playing the guitar, which you have always dreamed and you have never been able to do.
Do the things that you never always have time for.
Exactly. Not only cleaning the kitchen and the drawers, doing something fun as well. Otherwise, life is boring.
Oh, Prof, we miss you, mate. We miss you.
Thank you. Listen, can I steal a second just to say hello to all ladies in general, or patients, and particularly the ones that I've had the pleasure to treat and to take care of, and I'm really missing them as well. But I'm sure that they will be doing fine, and I keep very close. I treasure the time that we spent together very much.
Oh, do you know, you're amazing. You know what, the one thing I remember about you, Prof, the most is when I went down to theatre to get my mastectomy, and I'm laying on the bed about to go in, and you held my hand and you sang me to sleep.
Really?
You sang me to sleep, and I will never forget that. because I was going to sleep laughing, thinking, oh, that's really nice, and how cute is that? And then I was asleep. So I went to sleep in a good place. It was really nice. And you have got a lovely voice as well.
Thank you. Thank you very much. Thank you.
It meant a lot. So I do appreciate it. And I know all the patients appreciate you as well, because you put the patient first, and you're thinking of what that patient needs. You have a personal connection to your patient, and it's very much appreciated from all your patients.
That's the pleasure of being a physician. But also I need to congratulate you, Sam, for what you have achieved. And now not only you as a person and your family, the support that you've received, but also the team that you've set around you, and that's really important to work together with others. Lateral thinking, constructive criticism, this is what makes us better all the time.
Always
so thank you for this opportunity. Thank you very much.
Appreciate your time, Prof. Thank you so much. Bye-bye.
Thank you very much.